Yep.
Good evening, everybody. Thank you for joining me in this webinar about knee pain and specifically robotic joint replacement. So a little bit about myself. That's me. I'm part of the Riverside Orthopedic Specialist Group out in Bourbonnais. I am originally from the Chicagoland area, went to medical school up in Chicago, and then did my residency in St. Louis, and then my fellowship, which is basically a whole year geared towards hip and knee replacement surgery at the Cleveland Clinic. And so I was exposed to different technologies, including robotic joint replacement. So the topic today is going to be geared towards robotics, but we're going to talk a little bit about why we do robotic surgery and what we use it for, specifically joint pain. And so we're going to talk a little bit about, what the treatment options are, and then get into the details of the joint replacement surgery, and then further detail about the robot and how that helps us during robotic knee joint replacement surgery, as opposed to or as compared to traditional knee and hip replacements. So as you guys are all aware, your joints are very important, right? So for activity, the joints are basically lined with cartilage, and the cartilage is what provides our joints with the motion and the ability to move. And as we know, moving is what makes us do the things that we want to do. Two of the more important joints that I specifically focus on are the hip and knee joints. And so the hip and knee joint, the hip is a ball and socket joint, and the ball has a layer of cartilage that lines that ball, and the socket, which comes from the pelvis, is also lined with this cartilage, and this allows for a smooth motion, and it's painless. And the knee, on the other hand, is more like a hinge joint, but again, similarly, is lined with this cartilage that allows for a fluid motion that's painless and without any pain and deformity. However, as we realize, you can develop pathologies or diseases of these joints, and some of the more common diseases that we see in the elderly specifically is the arthritic problem. And so arthritis comes in many flavors, but the most common one that we see is osteoarthritis, and that's probably the one that most people are familiar with. And this is basically wear and tear arthritis. So what does that mean? As we age, the cartilage, that lining that we see at the edges of those bones, deteriorates. And so when that deteriorates, two things happen. One, it causes pain because we're starting to lose that nice cushiony surface. But number two is you develop friction, or what seems like friction in the bone, because you've lost that gliding surface. And so what does that friction present with? It presents with stiffness, right? Because the bones are rubbing when they're not meant to be rubbing. So that's what osteoarthritis is, and that's the most common type of arthritis. However, we do see other types of arthritis, rheumatoid arthritis, which is basically a inflammatory problem. It's a little different in terms of how it starts, but the end result is the same. The end result is that the cartilage starts to break down, and then when the cartilage starts to break down, you get pain and you get loss of motion, and that's what we're seeing. The last one that we do see, and there are other ones too, but one of the more common ones is post-traumatic arthritis, which is basically a fancy term for arthritis that develops after an injury. So whenever you have an injury to the cartilage sustains irreversible damage. When it sustains irreversible damage, we know that it can cause, again, degradation of the cartilage. We get bone on bone, and then that develops into friction, and that causes pain and loss of motion. So if you can understand that that's the underlying problem that we're seeing with arthritis, no matter what type of arthritis it is, then it's easy to realize the treatment options or how they work. When we talk about treatment options, the first and almost always we start with this is non-surgical management. So what does that mean? That means, we tell patients, if you have pain in the hip or the knee because of arthritis, with a certain activity, we have you try to limit that activity. The other way we can tell patients to help with the pain is by having them use some sort of an assistive device or a walking device, because this allows you to offload that joint, and it helps with pain. Heat or cold therapy can help and make the joint feel better. Generally, I recommend cold therapy to start because that causes a constricting effect, and so the blood flow to that area decreases. And when we decrease the blood flow to that joint, then we have less swelling, and we know that swelling causes pain. So we try to limit swelling in the joint, and that can be done with cold therapy. Physical therapy, and this is a tough one to get people to buy into, because people have pain and we tell them to go do exercises, but in all reality, this is actually very useful. You got to realize that this arthritis is a condition that's progressive, and it's not something that we can reverse. It's irreversible. So all these all these treatment options that we're presenting here are to help maintain function and maintain mobility. They're not there to reverse the problem. And so what physical therapy or even an exercise program by yourself allows you to do is maintain strength in the muscles that span that joint. So we know that if you have knee arthritis, for example, and you've got degradation of the cartilage, you've got bone on bone developing, when we strengthen the muscles around the knee, we lower the stresses across that joint, and that makes us feel better. We also note, like we talked about, what happens in arthritis, you lose motion, you get stiffness. Physical therapy and home exercises can help you regain some of that mobility or motion back in that joint. And that makes people feel better, and it makes them more functional. And then finally, we talk about medications. So what are the medications we usually recommend for arthritis? The simplest being Tylenol, which is an analgesic, which basically is a pain reliever. So we recommend Tylenol. The other ones that seem to work very well are anti-inflammatories, which are that they come in oral form, which is what Advil or Aleve is that we get over the counter, or they come in a steroid form, which is an injection that we inject into the knee, and that basically causes an anti-inflammatory effect, which is decreasing the inflammation in that knee and making it feel better. Once we tried or have attempted all those things, and the patient is still experiencing lots of pain and symptoms, and it's affecting their quality of life, then we would consider surgery. So what are the things that I like to ask patients to see if the hip or knee arthritis is affecting their quality of life is, does it affect your sleep? So when patients come to my office, one of the few questions that I ask them with regards to their activities that they're giving up is sleep. It's very important. If people aren't getting their proper sleep, then they're not going to feel good. And so that is a very big trigger for me to recommend surgery. The other things that I like to ask is this pain stopping you from playing with your grandkids? Or is it stopping you from gardening? Is it stopping you from walking in the grocery store? So simple things like that. And then finally, one of the things that we take for granted is walking up and down stairs or walking on uneven surfaces. Anybody who has hip or knee arthritis can attest to that and how painful that can be. And so those are some things that I like to ask. And if it's affecting those sorts of activities, I usually feel comfortable offering the patient surgery, because I think we can make them better. So what do we do in surgery? So when we talk about surgery, there are multiple options specifically for knee arthritis. I'll go into that in more detail here. So when you look at a knee in a cartoon model here, you can see the healthy knee. It's got that nice white cartilage at the edge of the bone. And you can see on the right, which is the arthritic knee, that the cartilage is worn away and you've got that nice bone being exposed there. And so that is what we're trying to address. It's important to realize that the knee has multiple areas. We break it down into 3 areas. The outside of the knee, which is considered the lateral side, which is the lateral compartment. The inside of the knee, which is considered the medial side, which is the gives way to the medial compartment, and then behind the kneecap, or the patellofemoral compartment. So when you have arthritis that affects one part of that knee or one compartment, we call that unicompartmental disease, meaning it's only affecting one compartment. Theoretically, if that's the only compartment that's affected, do we really need to replace the entire knee in doing so? And the answer to that question is no. So we'll get into that in a little bit, but if you look at this knee, for example, we've got a healthy knee on the right, we've got an arthritic knee on the, healthy knee on the left and an arthritic knee on the right. And you can see that the inside of that knee is completely worn away. And on the x-ray on the left, we see that the femur bone is on top of the tibia bone, but there's a gap between the two bones. So when we look at an x-ray, we look at weight-bearing x-rays, meaning with the patient standing up. When we look at the x-ray on the left, we see that the femur bone and the tibia bone has a gap. That bone isn't just floating on that tibia bone. There is something in between those two bones that is just not showing up on an x-ray, and that's what cartilage is. On the right, we see that the inside of that knee is affected. The outside of the knee seems like it's in reasonable shape. So we know that the cartilage on the inside of that knee is starting to wear away. So this is a total knee replacement. This is, most people think that when we do a knee replacement, we're going to replace we're going to cut a big bone block out and we're going to replace that with metal and plastic. And we don't do that. What we really do is we basically just shave down the bone, the edge of the bone, and we replace that with metal and plastic. And that's what this image is showing. We're going to see a little video here and that sort of shows what we do in a knee replacement, whether we do it with the robot or not. So you can see that we basically just shave the edge of that bone and we shave the top of the tibia bone and we replace that with metal or resurface that with metal and we put a plastic in between there. So that's all we're doing in a knee replacement. We're really not taking anything much more than that. We save all the ligaments, the tendons around the knee, which and all the soft tissues are still in place. So going back to that point about having disease in only one compartment, we can see that on the left that if we want to replace just one part of the knee, we can do that, and that's what a partial knee replacement is. So if you have disease in just the inside of the knee, there's no real reason to take that extra bone out. Then we would consider doing a partial knee replacement. On the other hand, if you have disease in more than one of those compartments, usually if you have disease in two compartments, I usually would recommend just going ahead and doing the total knee replacement. And again, this is the representation of that. So the inside of the first image, which shows the inside arthritis or medial arthritis, we see that you can replace just the inside of the knee. Similarly, if you have just lateral compartment or outside disease, we can just replace that. And then patellofemoral, which is behind the kneecap itself. The last picture does talk about theoretically you can do a medial and patellofemoral bicompartmental arthroplasty, which means you take the inside of the knee and behind the kneecap and you just replace those two parts. But as I alluded to earlier, when we have this type of a circumstance where you have two compartments or two parts of the knee that are being affected, it's just easier to go ahead and do the total knee replacement. So again, this is what an x-ray looks like. So we saw that x-ray earlier of that bone on bone with outside that was normal. And we see that in this case, we've replaced just the inside and we haven't touched the outside because it doesn't really look that disease. There's no bone on bone on the x-ray that we were seeing. And then on the right, we see a total knee replacement. And that's what the x-ray for that looks like, where we basically resurfaced the entire joint itself. It basically is a little bit of a larger surgery, as you can see there. So those are what the implants look like, the partial knee replacements on the left and then a total knee replacement on the right. And this is just talking to us about design. There are multiple manufacturers for knee design and we don't really support one over the other, but in terms of robotics, when we use a robot, it is specific to that implant. So multiple companies make multiple robots. So the robot that we have here at Riverside is called the Mako. And so with the Mako, you have to use the Mako's design knee. And that's what this is showing us. So this sort of leads us into the talk about Mako. So that's what Mako is on the right. It actually is a robot. And what does it do? Basically, Mako is a tool that we use in surgery that helps us get more predictable outcomes and more reproducible outcomes. And in doing so, we've noticed that there are certain advantages in doing so, such that people are recovering much quicker and they're using less pain medications after surgery. And so we noticed that not only is it giving us a more long-term benefit, but it's also more important than giving us a short-term benefit. So throughout the country, you know, the Mako robot has been around for quite some time. Initially, when it first came out, it was only used for partial knee replacements. Over the last 5 or 6 years, it's had the application for a full knee replacement or total knee replacement, and that's when it really took off. So now, you know, the overall data that we have is approximately 15 years now worth of data showing that it does a very good job of giving us short and longer term benefits. There's 150 research articles out there about it. There are multiple units across the nation. These numbers are from 2019, so they're probably much higher even now. So how does knee replacement with the Mako work? Basically, what you do is you get, well, I'll let you watch the video and then we'll talk a little bit more.
Let's take a look at how it works. We begin with the CT scan. A CT scan is a series of X-rays taken at different angles that can help surgeons see things they can't really see with an X-ray alone. The CT scan data is used to generate a 3D virtual model of the patient's unique anatomy. This virtual model is loaded into the Mako system software and is used to create a personalized preoperative plan. Prior to surgery, the surgeon reviews the plan size and placement of the implant, and if necessary, modifies the preoperative plan in order to better position the implant to the patient's unique anatomy. During surgery, the surgeon locates points on the knee in order to register the anatomy in the Mako system. This process establishes the relationship between the patient's actual anatomy in the operating room and the 3D model that was used during the planning process. This step helps ensure the procedure is executed to plan. Once the anatomy is registered to the 3D model, the surgeon has the flexibility to modify the preoperative plan based on their assessment of the patient's anatomy and range of motion. Then, the surgeon guides the robotic arm to remove the arthritic bone and cartilage from the knee. A virtual boundary provides tactile resistance to prevent the surgeon from removing more than just the arthritic bone identified in the preoperative plan. And visual cues, shown in green, appear on screen to show how much bone to remove. Collectively, these cues help the surgeon stay on the preoperative surgical plan. With the diseased bone gone, the knee implant is inserted into the joint space, and once the surgeon is comfortable with the knee's movement, it's off to the recovery room to begin the journey towards strengthening the knee joint.
So when comparing Mako knee replacement versus a non-robotic or non-Mako knee replacement, you know, what we see in a traditional approach is we basically don't have the same level of precision, and we don't have the same level of customization to the patient. So in a traditional knee replacement, what we do is we basically get an X-ray. We realize that the patient has inside disease or outside disease, and we basically in surgery we'll put a rod into the femur and put a cutting block based off that rod that we put in, and based on population studies and MRI studies that have looked at the anatomy of the femur, we know that most patients have a certain degree of bow to their end of the bone, and we make that cut based on that bow. So almost everybody gets a 5-degree cut. and on the femur side. On the tibia side, similarly, everybody gets a similar number cut, and so it's not very specific to the patient. But with the Mako, because we're using the CT scan, which is specific to you, it gives you a three-dimensional bone model, and so we can customize our cuts based on that CT scan. So we're not cutting, for example, 5 degrees off of the end of the femur bone. We're actually cutting maybe 4.7 degrees, and it's and we're not taking, maybe 8 millimeters of bone, we're maybe taking 7.5. So it's very individualized, it's very customized. And so that's where the advantage and precision of the robot comes in. And so, like the video alluded to, the first step is getting the CT scan. The CT scan develops a bone model. The bone model we use to determine what the angles are going to be, what the depth of our cuts are going to be. And even before surgery even begins, sometimes even prior to the day of surgery, we know what implant size we're going to use, what cuts we're going to make, what levels those cuts are going to be, what degrees they're going to be, and we sort of have almost like a video game model of the bone and the surgery. Then we come in surgery, we execute that plan, and this is where we see the other advantage of Mako, which is that in the execution phase, the robotic arm provides precision that a human surgeon cannot. And so when we're doing a traditional knee replacement, we have these cutting blocks, and we saw the bone within these cutting blocks. And so there is obviously inherently some imperfections that we sort of accept, and we can do that because we use cement to put the bone onto the implant onto the bone, and when we use cement to fill those imperfections. With the Mako, these cuts and these bony shavings that we're doing are so precise that we don't have that worry, and we've noticed that all these cuts are perfect. And so in surgery, we have the robot make the cut, we put the implants in, and then we go through our testing of the knee to make sure that everything is nicely fitting, everything is moving just as it should be, and then we put the final implant in after that. So recovery, in terms of recovery from surgery, is variable. So I don't want everybody to think that everyone's going to have the same type of recovery. It is a multifactorial issue. So, as you can imagine, somebody who's 85 and has severe osteoarthritis and they're severely debilitated and they live alone, or they live in an assisted living and they're not very independent, their recovery is going to be a lot different than somebody who has relatively mild deformity and mild arthritis. They have their activity level is much higher and they're younger, so their recovery is going to be much different than that first patient. So it's a very multifactorial thing. Usually what we do is we have surgery. Most people that are young and healthy and live that are living independently, they get to go home right away after surgery. The people that are a little bit older, that don't have help at home or live in an assisted facility, they go to some sort of a rehab facility. And again, it's variable. Everyone's recovery time can be different. Some people are recovering much quicker, some people are recovering much slower, but generally what we've seen with the robot is that most people recover quicker than they would have if they had a traditional approach. Most people, like I said, are going home. Some people are going home, going to a rehab facility. Most people that are going home either the same day or one day after surgery. The people that are going to rehab facilities tend to stay in the hospital a day or two longer. So it could be a little variable in terms of how long people are staying in the hospital. In terms of recovering from activities, this is also very variable, right? So the healthy 50-year-old patient who is independent, they may be off of any sort of assisted device in a couple of weeks. They may be driving in a couple of weeks. They may be back to work anywhere between 6 to 8 weeks. Somebody who's a little bit on the other spectrum, they may use a walker for a little bit longer, and they may use a cane for a little bit longer, and so they may need a whole 3 months to recover. So generally, I say anywhere between 6 weeks to 12 weeks for recovery. And then overall recovery, can linger for up to a year. And that doesn't necessarily mean pain. That just means not feeling completely back to 100%. And so you may have good days and bad days, but those good days may not be the more prominent feeling for up to 12 months after surgery. In terms of getting back to what you do, this is ultimately the reason we do this surgery is to try to get you back to these activities. Most people are able to do all of these activities without a problem. Walking certainly and biking certainly is a very realistic goal. Golfing as well is something that I get asked very frequently. And like I said, most of the people are getting back to these types of activities anywhere between 6 to 12 weeks in terms of golfing and biking and that kind of sort of stuff. There are certain things that we do recommend against, and I don't really have any, I don't put any restrictions on patients per se, but in terms of recommending against certain things there are certain things that we do try to avoid. One of the more important ones is skiing. Surprisingly, we've looked at multiple studies and skiing seems to be the worst thing that we can do on our joints just because of the torsional forces and the stresses that we put on the joint make it very susceptible to wear. And so long term, we try to avoid skiing. Now, having said that, I've had patients that specifically are skiers and want to go back to it, so I don't restrict them. I just tell them that you may be putting a little excessive stress on the joint, and this may lead to earlier wear. And as long as you realize that, go ahead and do it. Also, we recommend against high impact activities, so running, jumping, and basketball type of activities where we're putting a lot of impact activities on the joint, we usually tend to avoid. Having said that, I have patients that are playing basketball in rec leagues and running still on treadmills even after joint replacement. So again, it's not something that we say you absolutely cannot do this. It's just a recommendation that we don't, that we sort of are cognizant of it and are aware that we're probably going to wear the joint out a little bit sooner if we do these sorts of activities. So that's pretty much our talk today about Mako robotics. Hopefully we have some questions that I can specifically address here. I guess we have no questions. So thanks again for joining us today, and thanks again for letting me talk about the Mako. In the future, I think we probably will have these in a real live format where we can actually pass around implants and people can actually get to see a little bit more. But for now, under the circumstances, I think this is the best we can do. So if you have any questions specifically that arise that you can't think of now, feel free to reach out to us. Our number at the Riverside Orthopedic office is 815-802-7090, or you can always go on the website and find us that way. Thanks again and have a good night.